Hello everyone. Our topic is all about anemia associated with abnormal nuclear development, deoxyribonucleic acid, in short DNA disorders. Impaired deoxyribonucleic acid DNA metabolism causes systemic effects by impairing production of all rapidly dividing cells of the body. These are chiefly cells of the skin, the epithelium of the gastrointestinal tract, and the hematopoietic tissues. Megaloblastosis is almost always caused by deficiencies of vitamin B12 or folic acid. Number 1, megaloblastic anemia as a macrocytic condition. Macrocytosis caused by megaloblastic anemia must be differentiated from macrocytosis with a normoblastic marrow. Number 2, macrocytic anemia with a megaloblastic marrow can result in ineffective hematopoiesis. The laboratory profile of a patient who has megaloblastic anemia. In this table, it illustrates laboratory profiles of DNA disorders. Disorder, megaloblastic anemia. Characteristics: marrow has enlarged precursor cells. Blood smear RBC morphology shows macrocytes mixed with microcytes, moderate aneuploidy and poikilocytosis. Dacrocytes, basophilic stippling, whole jolly bodies, cabbage ring, and a few NRBCs. Laboratory profile: pancytopenia, low RBC count, low hemoglobin, low hematocrit, MCV greater than 100 FL, increase to normal MCH, leukopenia with hypersedimentation of neutrophils, mild thrombocytopenia, increased serum iron, and the bone marrow characterized by enlargement of precursor cells. Marrow is hypercellular because of increased APO stimulation. However, erythropoiesis is ineffective.
So, good day everyone. I'm going to report vitamin B12. Vitamin B12 or cyanocobalamin is a complex vitamin involved in the metabolism of protein and fats, DNA synthesis, normal blood cell formation, and nerve function. Metabolism. This usually occurs in the small intestines. Dietary B12 is released from digestions and animal proteins in meats and bound by gastric intrinsic factor. Normal serum vitamin B12 values is 200 to 900 nanogram per liter. Vitamin B12 function, cofactor in the conversion of methyl tetrahydrofolate, that is folic acid, to tetrahydrofolate. This substrate is an important cofactor needed for the production of thymidine, which is the DNA base. Common causes of vitamin B12 deficiency. The common cause of vitamin B12 deficiency is defective production of IF or intrinsic factor.
Good afternoon. My part of my report is about pernicious anemia. Pernicious anemia is a condition, nutritional deficiency of B12 caused by failure of the gastric mucosa to secrete IF. And also, the pernicious anemia is an inherited disorder, most common occurring in a person older than 40 years old. There are two types of autoantibody have been identified in PA patients. So the first one is an autoantibody that is directed against the perishal cells is found in 85% to 95% of NPA patients. And the second one is autoantibodies can also develop that are directed against IF or of the IF vitamin B12 complex. And other causes of PA, including the following. So the first is gastrectomy, removes the source of IF and results in megaloblastic anemia if vitamin B12 supplements are not provided. And defective absorption of vitamin B12 into the intestinal mucosal cell can result in a secondary vitamin B12 deficiency even if dietary intake is normal. And also, lack of availability of vitamin B12 in the small intestine can result from competition for dietary B12. So, in some also infestation with the fish tapeworm called Diphyllobothrium latum is common and result in vitamin B12 deficiency because the worm competes for the available dietary vitamin B12. And it also bacterial infestation in the blind loop of intestine also uses ingested vitamin B12. And for this, the pernicious anemia, the diagnosis of the vitamin B12 is based upon on clinical symptoms as well as laboratory results of the patients.
Good day. On this video, we will discuss about folic acid. So folate is the general term used for any form of the vitamin folic acid. So folic acid is the synthetic form in supplements and fortified food. So folate has an important role in DNA synthesis. So folic acid is needed for the synthesis of thymidine triphosphate and convert homocysteine to methionine. So where can we acquire folate? So good sources of folate include leafy green vegetables, dried beans, liver, beef, fortified breakfast cereals, and some fruits, especially oranges. Also, a smaller percentage is formed by intestinal flora. So for the daily dietary requirement, the minimum requirement has been set at 50 milligram, and dietary ingestion just barely meets the minimum daily requirement. And body's reserve lasts for only 3 months. So for the storage, the main storage site of folic acid is the liver tissue. And the normal serum reference values are 5 to 21 microgram per liter and 150 to 600 microgram per liter for RBC folate. So for this folate deficiency, clinically, symptoms from inadequate dietary folate can occur within weeks as compared with years for a vitamin B12 deficiency. So leukopenia and thrombocytopenia are less common with folate deficiency than vitamin B12 deficiency, but the symptoms and the hematologic profile are generally the same. Now, let's proceed with the causes of folate deficiency. So the first cause of this folate deficiency is inadequate intake. So folate is synthesized by microorganisms and higher plants. So folate is present in foods, but a generally poor diet and inadequate use of vegetables can result in deficiency. Unlike vitamin B12 deficiency, megaloblastic anemia caused by folate deficiency is most commonly due to this insufficient dietary intake. Again, as what I've mentioned earlier, folate is primarily acquired from the diet in such foods as example leafy green vegetables, milk, and some fruits. And also, folates are heat labile and overcooking of foods can diminish their nutritional value. So second, we have increased need. So a woman's demand for folate increases during pregnancy, and pregnant women should receive folate supplements of approximately 500 microgram per day. And infants and children also have increased need for folate during growth. So third, we have impaired absorption. So folate absorption may also be impaired by intestinal disease, especially sprue and celiac disease. So sprue is characterized by weakness, weight loss, and steatorrhea or fat in the feces, which is evidence that the intestine is not absorbing food properly. So it is seen in the tropical sprue, where its cause is generally considered to be overgrowth of enteric pathogens. So celiac disease or non-tropical sprue has been traced into intolerance of gluten in some grains and can be controlled by eliminating wheat, barley, and rye products from the diet. And surgical resection of the small intestine and inflammatory bowel disease can also decrease folate absorption. Then next, we have the impaired use of folate. So, numerous drugs decrease absorption of folic acid or impair folate metabolism. So, we have example here on this on the box 18.3. So antineoplastic, antibacterial, and anti-seizure agents are particularly known for this, and the result is macrocytosis with frank megaloblastic anemia. So because of folate deficiency results in inhibition of cell replication, several anti-cancer drugs including methotrexate are folate inhibitors. So in most instances, supplementation folic acid or reduced folic acid is sufficient to override the impairment and allow the patient to continue the therapy. So again, in this box 18.3, we have some drugs that may lead to impaired use of folate. We have the impaired folate metabolism and impaired folate for absorption. We have examples the antimicrobial, the pentamidine and trimethoprim, and for the absorption we have also antibiotics, which are the penicillins, and hormones, birth control pills, oral antidiabetic drug. This drug is the metformin. And lastly, excessive loss of folate. So physiologic loss of folate occurs through the kidney. So the amount is small and not a cause of deficiency. So patients undergoing renal dialysis lose folate in dialysate. However, thus supplemental folic acid is routinely provided to these individuals to prevent megaloblastic anemia.
Okay, now the last topic is diagnosis for vitamin B12 and folate deficiency. So currently we have different tests to determine if we are deficient or not of vitamin B12 and folate. First is the serum microbiologic assay. In this test, the bacteria is inoculated in a serum mixed in agar, then its growth is measured. If they grow in the media, this means that there is no deficiency. For the B12 deficiency assay, it uses Euglena gracilis or Lactobacillus leishmanii. Then for folate assay, it uses Lactobacillus casei. And next is the competitive protein binding radioassay. As its name implies, this measures the affinity between the labeled ligand to the target protein. This test is more rapid and widely used. For the B12 assay, it uses 57 co-labeled cobalamin, whereas for folate assay, it uses the 125 I-labeled folic acid derivative. Next is the Schilling test, named after Dr. Robert F. Schilling for his work on detection of radiocobalt-labeled vitamin B12 in urine. However, due to the recent advances of laboratory techniques, this test is no longer used today. This used to be the most specific test for differentiating pernicious anemia from other causes of vitamin B12 deficiency. For its specimen collection, the patient is given oral doses of vitamin B12 and their 24-hour urine level of cobalamin is studied. And then we have the deoxyuridine suppression test. This measures the marrow cells' utilization of deoxyuridine in DNA synthesis. Next is the urinary excretion assay, which is a specific test for vitamin B12 deficiency. In this test, the presence of methylmalonic acid in the urine is measured, which is the intermediate metabolite in vitamin B12 and folate synthesis. Okay, so your body makes large amounts of this metabolite if you have decreased level of vitamin B12. So, the excess amount will be excreted in your urine if you are vitamin B12 deficient. And last is the X-ray or endoscopic studies, which verify gastric atrophy and rule out gastric carcinoma. And that ends our report on anemia associated with abnormal nuclear development. Thank you for listening.